as we know that TAVI is an alternative to surgery in patients with severe aortic stenosis. And with the results from the partner 3 and evaluate low risk trials is also being done in low risk patients. So it is important for every TAVI center to thoroughly examine and monitor its practices. Keeping a detailed registry of the patients is essential for identifying the patients at risk of MACE and mortality. And also the anatomic peculiarities of Indian population impact the feasibility, procedure complication and long-term outcomes and need special attention. Therefore, we present a short-term follow-up study of outcomes of TAVI in Indian patients and examine the factors associated with the adverse outcomes. So a retrospective analysis was performed on all the patients who underwent TAVI from the January 2016 till June 2022. Baseline characteristics and outcome data was analyzed. Also, the outcomes of self-expandable versus balloon expandable valves were compared. Follow-up was done at discharge 1 month and 6 months and focused on study-defined MACE, all-cause mortality, new pacemaker implantation, echocardiographic measurements, paravalvular leak, contrast-induced nephropathy, and other peri-procedural adverse events. MACE was defined as composite of cardiac death, dissolving stroke, and/or major vascular complications. Appropriate statistical analysis was used. So a total 19 TAVI procedures were done during the study procedure, and all the patients were elected for TAVI after discussion in heart team. The baseline characteristics of the patients are shown in this table. Mean Euro 2 score was 5% and mean STS score was 3.4%, and most of the patients belong to intermediate risk category. Pre-procedure lab and echo parameters are shown in this table. And before TAVI, one patient has permanent AF and one had pre-existing LVB and 2 had a history of AVR done. And etiology of AS was bicuspid in 2 patients and degenerative in the rest other patients. So self-expandable Medtronic core valve, Evolute R and Evolute Pro valve was used in total 14 patients, while the balloon expandable Merir My valve was used in 5 patients. Pre-dilatation was done in the case of 9 patients and post-dilatation was done in 3 patients. And vascular closure was achieved with ProGlide, and in some 3 cases, Optira was also used. Mean volume of contrast used was 234 ml and mean procedural time was 168 minutes. So after the procedure, echocardiography showed a significant reduction in the mean and peak AV gradients. And there was no incidence of severe paravalvular leak, and 2 patients had moderate paravalvular leak after the procedure. There was a mean drop of hemoglobin of 1.1 gram and small rise of creatinine after the procedure. However, there was no major bleeding incidence, and 2 patients developed complete heart block, out of which 1 patient had undergone pacemaker implantation, other had transient complete heart block. And 2 patients developed new onset of LVB, and there was a mean rise of PR interval of 9.2 milliseconds after the procedure. We found that rate of new pacemaker implantation was 10.5%, that is in 2 patients, and contrast-induced nephropathy occurred in 4 patients. However, none of these patients required hemodialysis. So at 6 months, all-cause mortality MACE was 15.3%. We have total 3 mortalities. Out of these total 3 mortalities, 1 patient had in-hospital death, 1 had sudden cardiac arrest after 15 days, and 1 patient had non-cardiac death after 3 months. However, there was no incidence of valve embolization, coronary occlusion, aortic root rupture, and/or RV or LV perforation or tamponade. This table depicts the comparison of self-expandable versus balloon expandable valves. As we can see that the size of the valve implanted was significantly higher in the self-expandable group, that is 26.2 mm. However, the contrast volume used was more in the balloon expandable, that is 280 ml versus 217 ml. The incidence of mild MR was more in the self-expandable group, and need of pacemaker implantation was also significantly higher in self-expandable group. Other adverse events were comparable in both the groups. Coming to the predictors of mortality, we have done the Cox regression analysis was performed to evaluate the effect of several variables on the hazard of death at the mean follow-up 6 months. The significant variables in the model were PA systolic pressure more than 60 and prolongation of PR interval post-procedure. So the hazard ratio for PA systolic pressure more than 60 was 2.1, and For PR prolongation after TAVI, it was 1.5. So coming to the discussion, MACE rate in our study was 15.3, which is similar to the partner 2 trial. And total mortality was 15.8%, and it is also in accordance with other registries. No patient had stroke, even with the 47% pre-dilatation rate. And this finding is in agreement with direct and direct IV trial, which showed that there is no significant difference in stroke rates with or without pre-dilatation. In our study, new pacemaker implantation is similar, rate is similar to partner 2 trial, which is a intermediate risk trial. And it is all, we have seen that it was more in self-expandable valve group, which is in accordance to previous studies. And in another Indian study from Apollo Hospital, Chennai, the incidence of rate of new pacemaker implantation was 16%. Residual aortic regurgitation is an important predictor of mortality after TAVI procedure, and we have shown a very low incidence of moderate AR and no incidence of severe AR post-TAVI, which is similar to available India data. Results from France 2 registry have shown that an increase in the mortality with both patients with pre-existing and new onset of AF after TAVI. In our study, out of total 3 mortalities, 1 patient had pre-existing AF. TAVI patients with baseline pulmonary hypertension have significant all-cause increased mortality. In our study, 2 patients who died during follow-up had severe pulmonary hypertension prior to procedure. Also, Cox regression analysis showed that pulmonary hypertension is a predictor of mortality. So, conclusion, we have shown a good short-term results with low incidence of MACE, cardiac death, and stroke in Indian population. PS systolic pressure more than 60 and PR prolongation after the procedure are predictor of short-term mortality. Major limitation of our study are the limited number of patients and limited short-term follow-up 6 months. Thank you.